Ladies and gentlemen, it's my pleasure to introduce the first speaker, Juan Garcia Velasco, globally recognized expert in reproductive medicine and director of EV Madrid. Professor Velasco has contributed immensely to our understanding of ovarian stimulation and assisted reproductive technique. Today, he will be presenting his talk, ICSI for All. Please, Professor Velasco.
Thank you very much, Mr. Chairman, and thank you, Professor Atta, for inviting me to be here today in this debate about ICSI. And I'll give you my perspective. I'm a clinician, I'm not a lab person, so I can give you my view on how we handle ICSI. This is one of the, I think, one of the most hotly debated issues that we struggle on a daily basis. And there are advocates and we have opponents, and you know, we have good arguments in both sides. These are my disclosures, and basically, it's this. I have published not just one, but two papers saying just the opposite of what I'm going to defend today. So I'll do my best. So the idea is to be the devil's advocate and see why we should use liberally ICSI in many of our patients. Obviously, if we want to avoid the use of ICSI, we should treat the male first. And I think we can benefit our couples, especially the male factor will improve if we improve the diet, if we improve the lifestyle, and obviously if we minimize the body weight. We know this has an impact on sperm quality. But this is our wish. This is what we would like to have. But then the reality is different. This is what you order and what you get, right? The reality with our patients is that the mean age of our patients, female patients, is 38. We don't have a lot of time to wait for months to treat the male. These are the indications that we have in our lab. We use ICSI in more than half of our patients, 80% in donor oocytes because a lot of them are frozen oocytes, and of course 100% in vitrified oocytes, 100% in PETA, which could be again arguable, but we use it. And we have a 5% total fertilization failure as a whole. We know nature is great, but it's not perfect. We have 2 eyes, 2 kidneys, 2 hands, 2 lungs. Why? Because if one fails, you have the other. So fertilization failure does happen. Even in nature, errors happen. What do the guidelines say? And I agree with what has been discussed this morning. Guidelines are guidelines. Guidelines is not the law. There's nothing wrong doing anything that is not written in a guideline. It's a way to practice, but you can, if you have arguments and if you have an environment adequate, you can do things out of the guideline. And the guideline says that ASRM, you should use ICSI with frozen oocytes, and you should use ICSI for PET cases. And ESRE does not recommend to use ICSI in non-male infertility. And again, you can see one society being a bit more conservative than the other. But why ICSI overuse? Why do we use it so much? Well, it could be related to the insurance in some countries, which I argue with that. It could be clearly by patient preference. I think patients know the data. The patients that we see today in 2025, they have a huge amount of information, and they want to minimize risk as much as possible. It may help to minimize difficult communications when you have a fertilization failure and you have to start all again from scratch. Obviously, PET is increasing, so the use of ICSI is increasing. And there is incomplete awareness of the outcome. There's a lot of noise behind, but not so much information. So we will briefly discuss these 4 issues. If ICSI improves fertilization rate and cycle outcome, if it damages the oocyte, what are the neonatal risks, and what is the cost for the couple? And regarding fertilization rates and cycle outcome, if we take unexplained infertility, which is one of the key areas here, when we use ICSI in unexplained, and we do half and half, we split the oocytes and take half of them you do IVF, half of them you do ICSI. Usually with ICSI you have high fertilization rate. Sometimes you have similar, and in some cases, occasionally you may have lower, but in general, you have more embryos when you use ICSI. Complete fertilization failure is negated, reduced fertilization is minimized, and you have a higher oocyte utilization rate. So in unexplained, when you split IVF and ICSI, you have happier patients, you have reduced distress in the lab, and you have no adverse effects, according to the literature. What about damage of the oocyte? Well, if we do IVF, we know we have around 5% fertilization failure, which is, I think, today something that happens, but for couples is completely unacceptable. And sometimes we need to anticipate this because it may happen. We always have this criticism that ICSI bypasses numerous physiological processes, but this is what we do in fertility treatment. So does embryo transfer. We place the blastocyst in the uterine cavity where it should arrive in the tube. We do stimulated cycles, we do freezing, so all of these are obviously bypassing nature's concepts. We may identify 10 to 25 immature oocytes, which may not be valid for ICSI either way. We deselect oocytes because of the morphology, but does this mean that IVF is going to do better? I doubt it. There's a human selection of the sperm, but is human selection of the sperm, is it worse than nature? Cytoplasmic aspiration and worries about oocyte ultrastructure. ICSI was described more than 20 years ago, and I think we're still quite happy with the results. And there's also some concern about introducing PVP inside the oocyte, but what about the IVF lab? They use plastics continuously. What about the embryo transfer? You place the embryo in a catheter. So I don't see the concern here. And maybe we may have more fragile oocytes in advanced maternal age and even a lower fertilization rate when you have immature oocytes, maybe. There's data coming out. There was this abstract presented last year in ESRE by Bernstein. It was a randomized controlled trial in non-severe male factor, and they found, if you look at the data, similar fertilization failure and similar fertilization rate, whether you use IVF or ICSI. But if you look at the fertilization rate with ICSI, it's only 53.5%, which is, from my consideration, quite low. So this is why this data could be arguable. And there's, again, a lot of papers coming out. You have, for example, this one from China, from Wang, showing last year that probably ICSI was not needed in 2024, but the primary outcome was ongoing pregnancy rate after the first transfer. But we're talking about ICSI. What does pregnancy rate means? We should focus on the primary outcome, on what is happening in the lab, not what is happening after the embryo transfer, which success rates, as we know, may be related to many other factors. There was, again, this abstract presented by Paola Vigano at ESRE, taking HFA data with in unexplained and female infertility. Huge amount of data, and she showed that ICSI has lower implantation rate, higher miscarriage rate, and lower male babies. But this is real-world evidence, and when you look data from registries, you have a non-homogeneous population, you have a lot of confounders that you have to control for. This is not randomized, that requires sophisticated statistics, and obviously the classification of male factor in this huge database is not consistent. So again, interesting data to keep our eyes open, but not so clear about the deleterious effect. What about the babies? What about the neonatal risk? There's no increase in fetal or developmental abnormalities in children. The risks that have been described might be associated with paternal characteristics. If you look at the perinatal outcomes or long-term outcomes, and this is recent literature, they have similar physical health and metabolic and reproductive endpoints. And if we are worried about the imprinting disorders and DNA methylation, it seems that the epigenetic variation is quite limited. There's insufficient evidence for an association. They are largely resolved by adulthood, and there's no direct evidence that it impacts on development and health. So again, these concerns doesn't seem to be so solid. And regarding cost for couples, of course, the clinics have to invest in the hospitals on the equipment. The time from staff is significantly higher. The ICSI cost as average is 8.3 higher, but most of the hospitals, they do this as a package. So there's no price difference in whether you do IVF or ICSI. You will do whatever is required in the lab. So to conclude, I think we need to be open-minded. We need to move from paternalistic decisions from doctor to patients and adopt a compromise after being fully informed. Should we really accept data sets that, of course, our own prejudices and reject the others? Hopefully not. And ICSI improves fertilization rate, more embryos are generated, does not damage the oocyte, and does not increase neonatal risks. So I think the way we practice today is informing our patients and make a compromise with them with the decision. To finalize, and I know the jury is still here, just think about a patient, a case. Don't think in general about data and p-values and meta-analysis. Think about a patient. Think about the patient with the name. It could be Maria. This patient could be an individual patient that you're going to see when you go back from this meeting. She could be your partner. She could be your daughter. She could be your close friend. what would you do? Thank you very much.
Thank you very much. Have your seat, please. Our next speaker, Mete Işıkoğlu, a distinguished reproductive endocrinologist and IVF specialist, known for his extensive clinical experience and scientific contributions, IVF. Please have your stage.
Respectful Chairman, my dear friend Sami, thank you very much for the kind introduction, and I would like to express my gratitude to share this stage with a very highly scientific name, Dr. Velasco. Dear friends and colleagues, I have been tasked to convince you for preferring conventional IVF for insemination in non-male factor infertility cases. And in the end of my talk, I strongly believe that there will be a great change in your point of view. I do not have any conflict of interest regarding this issue. As Dr. Velasco mentioned, the ESHRE add-on working group published a paper entitled Good Practice Recommendations for Add-ons in Reproductive Medicine. And in accordance with this publication, when ICSI is used for non-male factor infertility, it's considered as an add-on treatment. Then a question comes up, what is an add-on treatment? An add-on is any variation from a conventional IVF cycle. And there are common features of add-ons. First of all, it's not essential. You don't have to do it to achieve your target. Second, it's claimed to be effective, but there's unproven benefit. The evidence is either missing or very weak. And also it has an additional cost. And for ICSI, we have some more concerns, including the health of the newborn. ICSI first introduced as a remedy to overcome the male factor infertility, but over the next 3 decades, its use expanded to other indications. For example, in United States, during a 15-year time frame, its use more than doubled, reaching up to 76% of all ART cycles. The situation is more or less similar in European continent. There was an increase, but with one exception. During the last 20 years, its rise stopped, but it's still used more than 2/3 of the cases. But the devil is in details. When you analyze all countries located in European continent, you can realize that in some countries, conventional IVF is not used at all. And these are generally Balkan countries. There is another group of countries, including Spain and Turkey, which are the main contributors of the cycles in European data set. And in these countries, ICSI is used in more than 75% of the cases. But when you exclude these 2 groups from the whole, you can realize that the remaining 24 countries prefer conventional IVF in majority of the ART cycles. At a global scale, we can say that in all continents, ICSI is used in more than half of the ART cycles, reaching up to 85% in Latin America. But there is a particular region, this is not a continent, a region, Middle East. In this part of the world, ICSI is used nearly as a routine insemination technique. You know this handsome guy, he's the inventor of ICSI, Dr. Gianpiero Palermo. As he's the inventor, we can consider him as the king of ICSI. And the king says that he applies ICSI in 80% of the ART cycles in his practice. Then we can say that if someone uses ICSI in more than 80%, then as the French says, he may be or she may be named as plus royaliste que le roi, which means more royalist than the king, or kraldan çok kralcı. In our clinic, we have been using conventional IVF since 2009, and over the years, its use declined steadily, and at the moment, we are using conventional IVF in our own practice in more than half of the ART cycles. In the bottom of the graph, you can realize a light green line showing the splitting of the eggs. Actually, we do not do this. We just do this strategy when we conduct a randomized controlled study. Here's a summary of the all well-designed and respectable randomized controlled studies from various regions of the world. All are multi-center studies, UK, Vietnam, China, and the last one is from Denmark. And you see the variables, including the fertilization rate, total fertility failure, fertilization failure, and implantation rate. In none of these parameters and in none of these studies, none of these parameters are statistically significant in favor of ICSI. The green ones show the parameters which are in favor of conventional IVF, and the ones framed in red rectangles are the ones which are statistically significant. For example, when you check the fertilization rate, in 3 of these well-designed studies is in favor of conventional IVF, and in 2 of them is significant. Strikingly, total fertilization failure is quite similar in all of these studies, even is in favor of conventional IVF in one of them, and the implantation rate is better in conventional IVF. Also, based on the data set of European IVF Monitoring Consortium, we can realize that the pregnancy rate per aspiration is better when you use conventional IVF in your practice. All the national and international guidelines, practice guidelines, clearly states that ICSI should be reserved only for male factor infertility or in cases with a history of fertilization failure. Then, what may be the reasons for the practitioners to choose ICSI in their practice? There are some presumptive reasons. Higher expectation of higher fertilization, lower fertilization failure, better clinical outcome, maybe work better in advanced stage patients or poor ovarian response, but the facts are completely different. IVF is either similar or works better, but we have a brand new indication for using ICSI, particularly in regions where ICSI is the routine method, because the new embryologists do not have the opportunity to have an observation or hands-on training of conventional IVF. I will mention the first 2, fertilization rate. Imagine that you have 2 identical patients and you collected the oocytes and you inseminated them, and when you calculate the fertilization rate, at this point, since you eliminated the immature oocytes in ICSI arm, you will have a higher fertilization rate in ICSI, but when you do the same calculation after changing the denominator of the equation, and you calculate the 2PN number of 2PNs per collected oocytes, the result will be opposite. For example, when you collected 10 oocytes and you do the denudation, you came upon 7 metaphase 2 oocytes, then you do the insemination. Even if you have higher number of embryos in IVF, the fertilization rate will be higher in ICSI. But when you repeat the calculation for the all collected oocytes, you will see that it will be the opposite. Then the statement that ICSI promises better fertilization rate is just a therapeutic illusion. The fact is IVF results in higher fertilization rate and higher number of embryos. The fertilization rate is, when fertilization rate is calculated by all collected oocytes, the studies show that, almost all studies show that it's better in IVF and it's statistically significant. We conducted also some studies. One was a prospective randomized one, and we found that the clinical outcome and the laboratory outcome were similar. We expanded our research to a particular group of poor ovarian reserve. Again, the laboratory parameters and the clinical outcome were similar, which means that low number of eggs is not an indication. Regarding total fertilization failure, if you have just one oocyte in your hand and assuming that the fertilization rate is 70%, if you come upon fertilization failure, it's statistically not significant. You must have at least 3 oocytes to say that it's a total fertilization failure. The reviews about the fertilization failure are really striking. There are a total of 7 reviews up to now. In one of them, total fertilization failure is not mentioned, but 4 out of the others, it's stated that the fertilization failure is similar in both insemination techniques. In only 2 of them, ICSI seems better, but in one of these 2 studies, the sibling oocytes were splitted, which means it may be a confounding factor since an experienced embryologist may imagine the maturity of the oocyte before denudation. Also, if you come upon fertilization failure, you don't have to switch to ICSI because the studies show that in a repeat cycle, the fertilization is at least 30% and reaching up to over 90% in some studies. There are some concerns because of the detrimental role of ICSI. These are the chromosome abnormalities, epigenetic changes, and congenital heart defects, and so on. There are lots of studies creating concerns about these issues. A striking one is a recent publication from the United States, including 1.5 million of births, and it shows that in ICSI, the birth defects are higher. Last but not the least, the long-term results are lacking for ICSI. And in conclusion, as an overview, we compare these insemination techniques regarding quite many parameters, and almost in all of them, IVF seems better, but ICSI is still popular, but we must keep in mind that what's right isn't always popular, and what's popular isn't always right. Thank you for listening.
Thank you very much, Mete. Have yours, please. Is there any question from the audience?
I am Dr. Sinem from American Hospital, Istanbul. Thank you, first of all, for the presentations. I want to ask your real opinion because for laboratory points of view, ICSI is better than IVF. They are, the timetable sorry, the timetable is okay. They work in the exact timetable, and they can plan their tomorrow. What do you think about this, actually? Sorry, I couldn't explain so well.
I understand the question is, what do we think about the lab position with IVF or ICSI? And I think for the planning in the lab. And to be honest, we don't allocate different timings for IVF or ICSI. In our setting is pretty standardized, the time per procedure. Obviously depends on how many oocytes you expect to retrieve, but it doesn't really matter whether it's IVF or ICSI. The timing is like the cost for the patient. Everything is the same. So it is true that we have a very liberal approach for ICSI, and as soon as you expect a mild male factor or anything that may go wrong, or even in unexplained, where we split the oocytes, the embryologists are ready to do ICSI in half of these oocytes, and the timing is planned exactly the same. So for the lab, the main benefit for them is in case you have a fertilization failure, because if you if you have it in IVF, and you may expect it in 5% of your cases, 5% seems low. The p-value may be non-significant or significant, but it's a patient I have to call and tell them, listen, we lost all the oocytes, there's no fertilization, you have to start again. This is a very stressing situation. This creates a lot of conflicts. It's not easy for the patient, it's not easy for the embryologist, not easy for the doctor. And if you did ICSI, you can discuss this question. If you only did IVF, you always have the question why you didn't try with ICSI. So this is why we allocate similar time, and this is why we have a liberal approach for ICSI.
And also I want to ask, for ESHRE, for example, conventional IVF is suggested most of the cases, but in reality, in Europe and especially Turkey, if the laboratory is experienced, they mostly doing ICSI. What do you think that cause of conflict in this situation?
Mete değiştiriver istersen.
Actually, we are a country in which ICSI is the routine insemination method, but as I showed in my slides, in European countries, it's not the reality. When we look at a global scale, the countries in which ICSI is routine are Balkan countries and Middle East countries, and I really think that it may be a cultural issue. Maybe the practitioners prefer to be on the safe side. But as a clinic performing IVF liberally, I can say that we are very happy. We have a private clinic, otherwise we wouldn't choose IVF as the preferred method. Particularly the patients in their 40s, in advanced stage patients, or the patients with limited number of eggs, it works really satisfactory.
Thank you. Ezgi?
If I may add,
sorry.
I think you have to take into consideration also the profile of your patients. And some clinics are strong referral centers for male factor, so they will have a 90 or 95% usage of ICSI, where others have a more diverse population, and they may go as low as 50%. But we know there are clinics who do 100% ICSI, and clinics who do 50% ICSI, and they both have excellent outcomes.
Thank you. Ezgi, next question.
A quick question. Would like to get your opinion from both of you. How about midpoint resolution for those where sperm doesn't have any fertilization before, whether naturally or by IUI, in unexplained infertility? 50% of the eggs for IVF, 50% for ICSI. What would be your approach or the way that you think?
In unexplained infertility without any previous fertilization, any miscarriage, anything like that, we do 50-50.
We try not to do splitting, because if you continue splitting, you will never switch to a real IVF program. Actually, there is a very large data of the Society of Assisted Reproductive Technologies from the United States, including all the huge data of the unexplained infertility cases, and in that study, none of the parameters are lower in IVF.
You wouldn't favor it at all?
Yeah, but we in our clinic, we have a defined metric index, which is calculated by the volume, the concentration, the progressive motility, and the morphology. If this index is over 100,000, we directly do conventional IVF. It's an arbitrary one, but we found it by time.
Thank you.
Ahmet abi, lütfen.
Thank you. Ahmet Zeki Işık from Izmir. Thank you, both of you. Personally, I argued with Mete several times in this issue. I want to add some few contributions and some questions during these contributions. One of them is Mete, during his challenging work, define a parameter to select the suitable cases for conventional. So it is better time for every lab to start with, even by splitting in the beginning, but maybe but then they can very safely define their parameters where the conventional IVF used for subfertility or unexplained infertility patients. But on the other hand, I agree with the presenter that the heterogeneous group of patients coming from different sides of the, maybe internationally, and most of the time there is always a male factor inside this group. I mean, there is not a group that more than 50% of cases the sperm analysis is normal. Always there is a problem with the morphology, with the velocity of the sperm, and so on. So in this case, we usually skip to the safe side and try to make ICSI. But I agree with Mete that there may be some patients may have advantage of getting more high quality embryos with a kind of selection with the egg and the sperm that may benefit from the IVF. So we should be careful if you are walking around in 90% ICSI or 100% of ICSI. We should chase the better, the parameters that we have to use this conventional IVF. Conventional IVF is also, he didn't mention here, most probably due to time, it's also cost effective. And for the time schedule, if you have, for example, 8 patients in one day in the row, and every of them has 20-25 oocytes, and let's say you have to deal with hundreds of oocytes, and the IVF is time consuming at that scenario. So if you go on with ICSI, you have to increase your the number of the embryologists. You have to pay more to the ICSI needles and other stuff. So this is another side of it. But for the side of safety, we have to define first the safer the threshold for the conventional IVF. But we have to do that. We should not get rid of it. We are on the safe side. We don't care about it. But we should not get rid of it. And the last time I want to tell, I don't believe that the technique, ICSI technique, increase the aneuploidy or increase the epigenetic phenomena. Over there, the patients with chromosomal aberrations, especially among the male, severe male factors, and the patients who do not have chance to get father and mother with without ICSI create this difference. So I don't agree with this side, but I agree with you on the other aspects. I want to contribute like that, and if there are some debatable points, I want comments from the speakers.
Thank you. Thank you very much. Last question, Ibrahim.
Right. Thank you very much for the nice presentations. My name is Ibrahim. I'm from ART. It's more like a comment. Normally, in most of the cases, whenever it's possible, we try to split between IVF and ICSI. And this inspired us to do this study because initially we did a study sibling oocytes for the same patient. We split IVF and ICSI, and we saw no difference in any of the total fertilization, blastulation, euploidy rate. But what was interesting is, the trade-off in difference in fertilization between ICSI and IVF is different. So with ICSI, we have higher degeneration. We don't get degeneration with IVF. At the same, with IVF, we have higher abnormal fertilization or no fertilization. So we end up with more or less similar 2PN or normal fertilization ratio. What we did is, we compared in the cycles that we did both techniques, and we looked into the cycles where we had high degeneration in ICSI or higher degeneration in ICSI, and the cycles where with IVF we had lower fertilization, and we found that combining both techniques in every cycle ended up with increasing the number of blastocysts available for the patient. Now, we cannot identify if this patient after ICSI will get high degeneration. And we cannot identify also the cases where with IVF you will get no fertilization or high abnormal fertilization. So maybe the safest approach is, when possible, is to split between the two methodologies.
Thank you. Thank you very much. It's time to end of this section. Shall we take photo? All audience, all speakers, please. Barış.